All right, let's talk viral hepatitis. Today, we're going to do a rapid-fire clinical boot camp on the 5 key viruses. This is tailored for what you need to know for your boards, for your rotations, and for your practice. Just the high-yield stuff, no fluff.
So here's our game plan. First, we're going to get a big picture overview of the whole family. Then, we'll dive into the enteric viruses, A and E, the ones that are transmitted through food and water. After that, we'll get into the real heavy hitter, the notoriously complex hepatitis B and its partner D. Then, we'll cover the amazing success story of hepatitis C, and we'll finish up with some absolutely essential clinical pearls on diagnosis and prevention that you can take with you.
All right, first things first, let's get a map of the territory. You have to understand the basic virology here, because this is the foundation for everything else we're going to talk about.
Okay, so right off the bat, this is the first major split you have to lock in your brain. 4 of these viruses, A, C, D, and E, are RNA viruses. But hepatitis B, it's the lone wolf. It's a DNA virus. And that one little difference is a huge deal. It's the reason its life cycle is so much more complicated, and why interpreting its labs is its own special skill.
Let's ease into it with the 2 viruses that share the same highway, so to speak. We're talking about the fecal-oral route. Yep, contaminated food and water. These are the ones you often hear about in the context of travel or local outbreaks. So for both Hep A and Hep E, the story is usually pretty simple, right? It's an acute illness, your body fights it off, and it doesn't become a chronic problem. You diagnose it by looking for that IgM antibody. And for Hep A, we've got a fantastic vaccine. But, and this is a huge but, that you absolutely cannot forget, hepatitis E in a pregnant woman is a totally different and devastating disease. It can cause fulminant hepatic failure, and the mortality rate is tragically high.
All right, buckle up. We're now getting into the absolute core of this whole thing. This is the high-yield stuff for your exams, for your rotations, understanding the beasts that is hepatitis B and its weird little sidekick, hepatitis D.
First marker you got to know, HBsAg. That's the surface antigen. If you see this on a lab report, it means one thing and one thing only. There is an active infection. The virus is there, it's replicating, and that person is infectious, period.
Now, the flip side of that coin is the surface antibody, anti-HBs. You see this, you can breathe a sigh of relief. The patient is protected, they're immune. This can happen 2 ways. Either they fought off a natural infection and won, or they got the vaccine. This is the goal.
Okay, now for the tricky one, the core antibody, anti-HBc. Think of this as your exposure marker. Here's the key pearl. You will never see this if someone's just been vaccinated. This proves they've seen the actual real virus. So if it's positive, how do you know if the infection is new or old? That's where IgM comes in. A positive IgM core antibody is screaming, "This just happened. This is a fresh infection within the last 6 months."
Okay, this table right here, this is basically your cheat sheet. This puts it all together. Just look at the difference between recovered and vaccinated. See that? They both have the protective surface antibody, but only the recovered person has that core antibody, proof they actually fought the virus. And then there's the window period. This is that super tricky spot where the antigen is gone, but the protective antibody isn't there yet. The only thing that's positive is that IgM core antibody. Seriously, burn these patterns into your brain.
So what's the deal with hepatitis D? Think of it as the ultimate freeloader. It's a broken, defective virus. It literally cannot do anything on its own. It needs hepatitis B to survive. Specifically, it needs that surface antigen, HBsAg, to even replicate and cause an infection. The takeaway is simple. No Hep B, no Hep D.
Okay, so we've navigated the complex stuff. Now let's talk about one of the biggest success stories in modern medicine, the story of hepatitis C.
You know, for the longest time, Hep C was the silent monster. Unlike hepatitis B, where most healthy adults can clear the acute infection, if you got acute Hep C, the chances were very, very high that it was going to stick around and become a chronic, smoldering problem, eventually leading to cirrhosis and liver cancer.
But then, everything changed. And I mean, everything. With these new drugs, the direct-acting antivirals, or DAAs, the cure rate is now over 95%. Think about that. We went from grueling, often ineffective treatments to a simple course of pills that can completely eradicate the virus. It's absolutely incredible.
All right, let's bring this all home. We're going to wrap up with some key clinical pearls.
The stuff you absolutely have to have in your back pocket, ready to go for your exams and, more importantly, for your patients.
So what's the bottom line here? It's all about proactive screening. The guidelines are crystal clear. Every single adult should be screened for Hep B at least once. Every pregnant woman needs to be screened for HBsAg. And this is a big one. Always screen for all 3 HBV markers before you put someone on immunosuppressive therapy. You do not want to risk waking up a sleeping giant and causing a fatal reactivation.
Let's run through a classic scenario. You're unvaccinated and you get a needle stick from a patient who you know is HBsAg positive. The clock is ticking. What do? It's a two-pronged attack, and you do it right away. First, you give HBIG, that's hepatitis B immune globulin, for instant passive protection. At the exact same time, you start the hepatitis B vaccine series to build that long-term active immunity. You absolutely need to do both.
So I'll leave you with this final thought to chew on. You get the lab results back. Your pregnant patient is HBsAg positive. What is your immediate next move to protect that newborn? This isn't just a test question. This is where all that virology and serology comes together to literally change a life. How do you apply this knowledge to break that chain of transmission and protect the next generation?